She then stayed at Columbia, where she went onto the faculty and built a research program that focuses on psychiatric and substance use epidemiology across the life course. This includes early origins of child and adult health and cross-generational cohort effects on substance use, mental health, injury outcomes, including suicide and overdose. She does a lot of work on methodological challenges in estimating age, period, cohort effects, as well as mathematical agent-based and other simulation models to inform public health and public policy interventions. So her work has generated over 350 peer-reviewed publications. She's the author of 2 different textbooks, and she promises to put some data about what's happening in Arizona into her talk today. So you'll be hearing about some of our local situations. Anyway, her talk today is titled, and you can see it up there, Suicide Clusters, Spatial and Temporal Correlations, and their Environmental and Social Determinants in the United States. So let's welcome Carrie.
Thank you so much, and thanks for inviting me and for the opportunity. And I now just realized I did take my material in Arizona out for time because I added some additional studies today. So I just don't want to overpromise and underdeliver, but I'm happy to talk about Arizona in the Q&A because I have done quite a bit of work on suicide and overdose in the state. So I just want to preface by saying that this talk is going to focus on suicide and suicide deaths. And this is a topic that's really personal for a lot of people, and it is for me too. I'm also a suicide loss survivor. And I just want to let people know that now might not be the best time. If you're struggling personally, your family's struggling, this type of material might not be what you need to hear right now, might be distressing. And if anyone wants to leave the room at any point, no questions asked, is totally fine. It happens a lot when I give these talks. So just know that we're all in this together, and a lot of us have a suicide loss story. So with that being said, I'll start with just an overall kind of 10,000-foot view on what we know about recorded suicide rates in the United States. These are the recorded suicide mortality trends from 1900 through 2020, and I'll show you what's happened since 2020 on the next slide. I point out a few things here. One is that recorded suicide mortality was actually much higher than it is now in the US in the first half of the 20th century. I say recorded because there have been changes over time, of course, in how we record suicide deaths. And there's a lot of misclassification of deaths throughout the country. But the recorded suicide rate was much higher in the first part of the century. The other thing to keep in mind is that suicide rates were actually going precipitously down in the US throughout the 1990s until about the year 2000, in which there was an upturn in suicide deaths that really began accelerating through 2019, 2020. And so if you look at this recorded suicide rate in the US in 2020, it's almost exactly the same as it was in 1900. So while there have been fluctuations over time, we're really not making overall progress as a country in systematically and in an enduring way affecting the suicide rate. Here are the data organized since the year 2000. So this is that year where suicide rates really started increasing after their decline throughout the 1990s. And you can see that, similar to the last slide, suicide rates really have been increasing. And they started a downturn right around the time of the pandemic, but that downturn was not sustained. And so for the last few years, this data point right here is the suicide rate in 2023. And so you can see for the last 3 years, it's been relatively stable. That overall, this is a little bit fuzzy, but that overall suicide rate does mask a lot of age-related heterogeneity. And just a few things I'll point out. These are the suicide rates by age in the US. Females on the left, males on the right. Notice that the axes are really different. Males have a much higher suicide rate than females. So it only goes to 12 per 100,000 over here, whereas it's 50 per 100,000 over there. But for young females, for example, between the age of 15 and 24, you can see that there has been rapid acceleration in the fatal suicide rate since 2002. And that's also true for young males as well. But the difference is that among males, you see relatively rapid increases in other ages as well. So a lot of my research program is trying to unpack these trends in different ways. And what I'm going to talk about today is 2 dimensions that we really try to look at in epidemiology, which is the spatial dimension, how are suicides clustering in space, and the temporal dimension, how are they clustering across ages, periods, and cohorts, and then how we can understand how new and novel risk factors are contributing to that. So I'll start with a story that underlies a lot of what we think about when we think about spatial correlations of suicide risk. And this is the story of The Sorrows of Young Werther. This was a book written by Goethe in 1774. It tells the story of a young man who experiences unrequited love, and he takes his own life in the story. It was a sensation when it was published, and there were reports of young men of similar ages taking their lives, dying by suicide in the same way as Werther. So much so that the book ended up being banned in many different countries across Europe during the time. And so since then, and sort of throughout the 20th and 21st century, we've coined this term the Werther effect, which is when we see these spatial correlations of suicide arising due to what we think of as a contagion effect. It can be from fictional stories, it can be from high-profile, inappropriately reported celebrity suicide. We do see population increases in the suicide rate after these fictional and real-life deaths. There have been numerous meta-analyses of the Werther effect. You see it both in the US and across many other countries. This is the most recent meta-analysis of high-profile celebrity suicide from across a whole range of different countries. But overall, you can expect about a 13% increase. The overall meta-analyzed risk ratio is 1.13. So about a 13% increase in the population rates of suicide when there is an inappropriately reported celebrity suicide. We had such an event in the United States about 10 years ago now that we've extensively documented in the empirical literature, both in the US and in several other countries, and that was the death of the entertainer Robin Williams, comedian and entertainer. Shown here are the suicide rates by month in the US starting in 2010, and then 2011, 2012, 2013, and that red line is the suicide rate in the US in 2014, and this is the month that Robin Williams died by suicide. We used ARIMA modeling, time series modeling, to try to separate out the overall seasonality of suicide risk and the overall yearly trends in suicide risk that were already occurring. And we can estimate from those models that there was an excess of about 1,800 suicides due to the death of Robin Williams that would not have occurred otherwise. It's correlated demographically with people who are the same demographics as Robin Williams and dying using a similar method. So all of this has led my research group, and in collaboration with my colleagues at the Mailman School of Public Health from across departments. In particular, I collaborate a lot with this work with the environmental health sciences and the infectious disease modelers in that department to really rethink how we think about the risk factors for suicide. I think a lot of us are used to thinking about what, in Epi 1, when we teach Epidemiology 1 in Columbia, we tell people about agent, host, and environment as contributors to infectious disease epidemics. And so we've kind of tried to rethink suicide risk factors into the agent, host, and environmental factors that also influence suicide risk. So the host factors are what we typically study in psychology and a lot of other fields. Did the person have a psychiatric disorder history? Did they have previous attempts? Is there a family history? What stressful life events were occurring for this person? But in epidemiology, we also really think about these two other dimensions of the agent and the environment. So we study a lot of seasonality of suicide attempts and suicide deaths, how temperature and altitude and macroeconomic factors influence the occurrence of suicide, and also these agent factors. How is the media reporting high-profile celebrity suicides? What are the contagion parameters, for example, close contact with someone who is a suicide decedent, and firearm ownership in the home as other kinds of determinants for risk of suicide death. So with that kind of background in mind, I'm going to present some of the work that we're doing on the spatial and temporal correlation of suicide risk in the United States across these kind of 4 areas. First, I'll tell you a little bit about how we estimate spatial correlations, temporal correlations, new risk factors, especially around digital technology. And then I'll show you an example of how we then incorporate all that information into dynamical systems modeling to try to project things like what is the reproductive rate of suicide when someone in your community dies. So starting with spatial correlations. So this is an example of how we estimate spatial correlations. And right now it looks like just a mishmash of things that you can't understand. But these are the suicide rates by race in the US from 2000 to 2019 for people 5 to 25 years old. And each of these bars, so just focus on this top left one, each of these bars represents an area of the United States where the suicide rate was higher or lower than what the suicide rate would be expected to be if suicides don't cluster by space and time. So we use cylindrical scan models that scan windows for each month, quarter, and year in the United States and re-estimate the suicide risk for every single county and cluster of counties in the United States for each of those different windows and continuously re-estimate the relative risk of dying by suicide in that area under the null hypothesis that there's no spatial correlation. So what this bar right here represents is a cluster of 11 counties, that's what the 11 means, that in late 2004, early 2005, the risk of dying by suicide in those 11 counties was 4 times higher than we would estimate if there's no spatial autocorrelation in suicide risk. So each of these bars represents one cluster of counties. So this is one county over here where in 2000, the risk of dying was twice as high in that one county compared to if there was no spatial correlation. And a couple things that I want to point out here. One is that you can see that the number of clusters is getting greater, right? By the end of the data series, by 2020, you can't even differentiate some of these numbers. You can't really see how many counties are in each of these clusters. The other thing that you'll see here is that these clusters below 0 are also increasing in frequency. Those are what we call cold clusters. Those are areas of the United States where the risk of dying by suicide is lower than we would anticipate if there's no spatial correlation of suicide. What this together indicates is that there's just increasing heterogeneity in the United States of where suicides are occurring and where they're not occurring. The places that are high risk are getting higher, and the places that are low risk are getting lower. There's just a divergence across the United States that's been happening across the last 20 years in what are high-risk places for suicide and what are low-risk places for suicide. And here's just another example of this. This is another approach that we tried to really try to estimate that, where we use a latent class model at the county level. So we took all the counties in the United States across 20 years of data, 2006 through 2020. And we applied a latent class model to see if we could organize counties by their suicide risk at baseline in 2006 and by the slope of their change in suicide across time. And essentially what we found is a 5-class model, best fits all of the counties in the United States. And those classes are differentiated by where the suicide rate started and where the suicide rate ended. So for example, down here, there are 17% of counties in the US that have the lowest suicide risk. They started at 10.7 per 100,000. They ended at 13.7 per 100,000. So an increase, but the lowest amount of increase across the United States. And here's where those counties occur. Any county that's colored purple is in that 17%. By and large, they're largely on the coast. And then you can see each group of suicide counties getting higher and higher and higher in risk. 24% of counties in blue, 32% in red, 20% in green. And then these 5% of counties that are largely in the mountain regions, and including Arizona, are in the highest risk category. So these are 5% of counties that started at 19.6 and ended at 31.6 in terms of the suicide rate. And I think it's important to note that there's no group of counties in the US that we could statistically identify where the suicide rate is going down. So it's just the amount of increase that we're seeing. Okay, so we know that these suicides are clustering spatially, and I can answer more questions and get into more details. We've looked at a lot of macroeconomic risk factors for some of these trajectories. So if people are interested in that, we can talk about it in the discussion section. But I'll move on to also talking about then how we tease apart that spatial correlation dynamically across development. And we do that with age period cohort models. So I'll show you an example and I'm going to walk you through it, so don't get nervous. So these are the same data, all of the suicides in the United States throughout the same time period, from 2000 to 2020. On the left here is men, firearm suicides and non-firearm suicides. And on the right is women, firearm suicides and non-firearm suicides. So what we do in an age period cohort model, or in this visualization of the age period cohort model, is that we organize all of the person time that underlies each of the clusters of suicide death by age period and cohort in a hexagonal map. So each of these hexagons represents the combination of person time for a particular age at a particular year for a particular cohort. And then we map all the suicide rates for each of those adjacent hexagons, because as you can imagine, there's a lot of overlap as people move through time in those ages, periods, and cohorts. And by doing this visualization, a lot of interesting, I think, information emerges. So first, these A's over on this axis represent the suicide rate as people age through developmental time. You can see the suicide rate is very low among children. It starts to accelerate in adolescence and young adulthood. By middle adulthood, it's accelerating even more, and the highest suicide rates in the United States are for firearm suicides for men over 75. And so you can very clearly see those age effects in this graph as you go from black, which is the lowest risk, up through red and blue. You can also see the period effects emerging over time. These are just the overall suicide rates in the United States. You can see that there's more red hexagons emerging in the later periods than were occurring in these earlier periods. But you can also see this third axis is the cohort effect. So this is each cohort's experience as each cohort is aging through the life course. And where you see evidence of a cohort effect is when you see that clustering occurring. So here you can see a big pocket of red occurring. For non-firearm suicides, it's a little bit younger, but you can see a big pocket of red occurring here. For women who have much lower suicide rates in general, you can see the colors are changing, in particular for women in midlife, for both firearm and non-firearm suicides. These are cohort effects. These are groups of people defined by when they were born that are carrying with them a higher suicide rate at each age as they move through time than their age-specific counterparts in previous generations. So for men, it's men in middle age who are right now in their 50s and 60s who have a higher risk of death by firearm from suicide than men in middle age in that same age bracket in previous generations. And for non-firearm suicides, it's a little bit younger. And you can also see these emerging pockets of very young people where there's an emergent cohort effect, especially for non-firearm suicides. And you can see that in particular for women. You can see there's that big cluster of kind of white dots that's now extending down through the 20s and the teens. And this indicates this cohort effect where, in particular, non-firearm suicides are particularly increasing. There's also emergent disparities in this. We published a paper solely focused on Black women because the data are so concerning about cohort-related trends in Black women's suicide rates. And you can see down here for very young Black women who are in their teens and their 20s, especially in more recent periods, there has been a rapid acceleration in the suicide rate, and especially non-firearm suicides occurring for those cohorts. Just to emphasize this even more, we are seeing these big shifts in the methods of suicide death, moving away, especially for women, from firearm methods. So these are among all suicide deaths, the proportion that were due to asphyxiation, which is firearm suicides are the most common method of suicide in the United States, seconded by asphyxiation. And then there's kind of a bucket of all other methods of suicide death. And you can see for women in the early part of the 2000s, firearm suicides were the modal method of suicide death, but asphyxiation has quickly taken over. And by about 2000, over half of suicides among women were due to asphyxiation. For men, there was an increase in asphyxiation deaths kind of during that period, but it never surpassed the rate for firearm suicides and has gone down a bit in recent years, but still the gap is shrinking for asphyxiation deaths and firearm deaths for men as well. This is just a breakdown by race and ethnicity, just to show you. So these are the proportion of deaths due to asphyxiation among suicide deaths by race. You can see, for example, that among American Indian and Alaska Native, 53% of suicides were by asphyxiation in 1999 through 2001, and we're up to 3/4 now that are asphyxiation-related deaths. And I think this is a real challenge for suicide prevention, because when we talk about firearm suicides, which again still are the most common method of suicide in the United States, we have language to talk about how safe storage or secure storage, as people say now, and other methods of policy interventions that might be a way to separate someone from a firearm when they're in a moment of crisis. Asphyxiation deaths are much harder outside of institutionalized settings. It's very difficult to restrict access to lethal means when we're talking about asphyxiation deaths, and really suggests that we have to focus on the underlying suicidal crisis if means restrictions is really not an option at a general population level. We've demonstrated this a lot in a whole range of different papers, just how much non-firearm deaths are contributing to the increase in the suicide rates over time. So I'll just show you, this is a paper that we did where we did mediation of age period cohort models. So we included a whole bunch of different mediators of why the cohort effects are occurring and tested those mediation models. And I just wanted to show this slide because we tested how the extent to which changes in firearm ownership over time explain changes over time in suicide rates and in firearm suicide rates. And I'm showing this slide because basically what we found, this ranks every state in the US from the state with the lowest household firearm ownership rate to the state with the highest household firearm ownership rate. And in gray is the firearm-related suicide rate. The correlation of those two lines is 0.81. Essentially, in our mediation models, we can explain almost all of the state-by-state variation in the firearm suicide rate by firearm ownership. There's no other mediator that comes close. And almost all of the variation, the spatial variation in state-by-state suicide rates is explained by state-by-state variation in firearm ownership rates. But none of the mediation in the cohort effect is explained by changes in firearm ownership rates. So it explains, if you want to know why Montana has a higher suicide rate than New Jersey, it's because Montana has more guns. But it doesn't explain why suicide rates are going up in New Jersey and Montana. Something else is going on because a lot of that increase is non-firearm suicides. Okay, I'm doing good on time. So that's just an example of some of the things we do with the spatial correlation and the temporal correlation. And I wanted to change gears and talk a little bit about the work that we're doing on changing risk factors. And I'll start by saying that the major risk factors for suicide are not changing. We have done a lot of work on childhood adversity, which I know a lot of people in this room are interested in, using epidemiological methods. So this is a paper that we did several years ago where we estimated the population attributable risk of the major causes of disease and death in the United States that's due to childhood adversity. We calculate population attributable risks. I don't know if anyone's taken Epi1 or Epi2 maybe. Sometimes Epi1 doesn't cover population attributable risk. But essentially, we take prevalence estimates. We take estimates of the national prevalence of different kinds of childhood adversities. And then we took meta-analyses of the association between different amounts of childhood adversity and each of the 10 biggest causes of death and disease in the United States. And we estimated the proportion of those deaths that is due to childhood adversity. Suicide is always at the top. More deaths from suicide are attributable to childhood adversity. This is a little bit hard to see. But essentially, for example, for individuals who experience 4 or more childhood adversities, almost half of suicides are attributable to those childhood experiences. So childhood adversities contribute to a lot of major causes of disease in the US, but especially to suicide. So shown here is the actual number of US deaths that's attributable to childhood adversity. A lot of heart disease, a lot of cancer, a lot of chronic lower respiratory disease, but almost all suicides are attributable in some way to the early life experiences and early life adversity. And that hasn't changed across time. So as we're thinking about new risk factors, digital risk factors, I think it's important to note that really the bread and butter suicide prevention really has to focus on the child, the family, and the school environment. And the other thing I'll say before talking about digital risk factors is that public policies to prevent suicide death still remain our most important vehicle to prevention. My friend and colleague Jonathan Pirtle and I published a scoping review this year in the annual reviews of public health, where we went through all the different policies in the United States that have an empirical evidence base for reducing suicide deaths. They range from policies that influence structural determinants, things like minimum wage benefits, unemployment benefits, food assistance, paid sick leave benefits. All of those policies have an empirical evidence base demonstrating an association for suicide, a reduction in suicide death. Policies that prevent social exclusion, policies that limit access to alcohol and tobacco. And then we have buckets of policies that increase access to clinical services, so Medicaid expansion being an example of that. And then the policies that make it more difficult to access lethal means. For example, policies to limit access to firearms, policies that modify the built environment, putting netting on bridges, for example. There's a wide empirical evidence base that those reduce the population suicide rate. They do not displace suicides to other means. They really are suicide prevention interventions. So I just want to keep that in mind, that I think our focus in general should be on the risk factors we know to work and the policies that we know to work. That being said, there's a whole lot going on in the space of digital technology and the influence on suicide death. And what my colleagues and I have focused a lot on is not just the amount of time kids and adolescents and all of us are spending on our devices, but what content we're seeing. And there have been a number of general population studies now that have shown that about 25 to 30% of adolescents in the United States regularly see pro-suicide content on their phones. Among kids with a history of suicide attempts, 75% regularly see pro-suicide content on their phones. We've been particularly focused on these chat forums that are largely unmoderated. They're largely not hosted in the United States. And they are pro-suicide forums where people who are in suicidal crisis can go on and learn about ways to die. One of these, this was widely reported on in the New York Times in 2021. And in that article, they named one of the most egregious and popular of these sites. We did an analysis of just the New York Times publication alone on the number of searches, the number of Google searches for that website after the New York Times published their story. This is the number of website searches before. This is the number of website searches for that site the week that the New York Times story was reported. The number of searches went down, but our interrupted time series analysis indicated that it never went back down to the pre-publication levels. You can't put that genie back in the bottle. We then followed up that paper with a distributed lag model where we took the number of Google searches for this website, and it's just number of Google searches. We don't actually know, we don't track people who don't use Google to go to the site. We don't know whether someone who Google searched that site really went to it, how much time they spent on it. It's just number of Google searches, so quite crude. But essentially what we do, and then we correlated it with every single month's suicide rate in the United States across time. So the monthly Google searches for this site and several other pro-suicide websites, but there's one particular site that really overwhelmingly is searched, and the monthly suicide rates. So down here on this axis is the relative search volume, and the actual metric of relative search volume is very difficult to interpret. But essentially, I think what's important is as this axis goes up, more people are searching the site. And then here on this axis is the lag. So we correlated relative search volume with monthly suicides in that same month, a month earlier, a month later, 2 months earlier, 2 months later, et cetera. And this slide is for individuals age 10 to 24. If you look overall, you see no association between the relative search volume for pro-suicide websites and the monthly suicide rate. You also don't see any associations when you separate out by male and female. Where you really see strong signals of an association is by method, and in particular suffocation, which is the method that's most increasing in the United States right now, asphyxiation. We found that as the relative search volume for pro-suicide websites goes up, the number of kids and young adults aged 10 to 24 who are killing themselves by suffocation also goes up, especially at a lag of 0 months. So again, these are ecological data, 10,000-foot view, Google searches only, but there's a signal there of something that is concerning. We also saw a signal for poisoning. Poisoning and suffocation are the two most common methods that are recommended on pro-suicide websites. And interestingly, firearm suicides are very much discouraged on pro-suicide websites because the potential for long-term disability if you survive a firearm suicide attempt is quite high. We also saw the same sort of signals for an association for older adults, people aged 25 to 64, specifically and especially around poisoning deaths, and again at that 0 lag. And again, poisoning deaths are not only the most encouraged method of suicide on these websites, but for a number of years during the time period of this study, there's two substances that people tend to recommend on these sites to mix together. And on Amazon, if you put one in your cart, it recommended that you buy the other one. They've stopped doing that now, but during the time period of this study, it was not only quite easy to get this information, but the marketplace was making it even easier. So we see these as signals of an association. Obviously, there's a lot of limitations to this kind of work, but I think it's an important direction. Now, as we're moving into AI and ChatGPT models, there's even more reason to be studying these patterns of use, not only amount of use. There's right now 8 lawsuits against AI companies related to child suicide deaths. People have probably seen this extensively reported in the media, and I found this particularly chilling. This was a congressional hearing where the parents of children who've died by suicide were testifying to Congress. And these parents said, ChatGPT told my son, let's make this space the first place where someone actually sees you. ChatGPT encouraged Adam's darkest thoughts and pushed him forward. When Adam worried that we, his parents, would blame ourselves if he ended his life, ChatGPT told him, that doesn't mean you owe them survival. And then the chatbot offered to write him a suicide note. This is a real crisis that I think demands that we have dedicated research funding to really understand how young people are using these chatbots, what sort of guardrails are in place for them. Companies are not incentivized to do suicide prevention, even though they say that they care about this topic. You need dedicated people who have experience in suicide prevention to really guide those efforts. And so my fear is that this work that we're doing on pro-suicide websites is going to be dwarfed when these other technologies come into place and available to young people. We've also been focused a lot, again, trying to move away from these measures of like how much time you're spending on your phone, things like that, to these measures of the content that you're seeing and the way that you're feeling when you're using devices. So there's been a lot of discussion around this idea of social media addiction. And so I'm going to show you a little bit of our work on social media addiction, but I just want to point out that this idea has been around for a long time. So the idea of internet addiction was first coined in 1996. And a lot of these similar types of addiction models have been placed on a lot of different behavioral patterns: video game addiction, shopping addiction, et cetera. But for 20 years and more, we've had a model of internet addiction, where it's essentially, are you preoccupied with the things that you're doing online? Have you made unsuccessful efforts to quit or cut down on your use? Do you feel moody and irritable after you stopped using the internet, or you get cut off from the internet for some period of time? And this has really emerged, now over the last 20, 25 years, the names of these types of patterns have changed. We had internet gaming disorder. Then for a long time, there was Facebook addiction disorder, FAD. Now you'll see a lot in the literature called social media addiction. This one is my favorite, which is nomophobia, fear of no mobile phone, which really, when I leave my house and I realize I don't have my cell phone, it's like, oh no, I do get a little anxious. But nomophobia I've seen popping up in the literature as well. But all of these is that there's an impulse control issue. You can't control your use. You feel bad when you use or when you stop using. And so there's a lot of correlates with these other kinds of addictive disorders. But the problem is that, like all things in psychiatry, there's a whole bunch of comorbidity. So the extent to which this is real unique phenomenology remains to be seen. Nevertheless, there are numerous treatments for social media addiction and other kinds of internet addiction that are gaining traction. But just to say, we've used longitudinal, population-based, nationally representative data to estimate the amount of social media addiction that is occurring among kids in the United States and its correlation with outcomes. And the one thing that I will say is that when you study the literature on social media and mental health, basically what you find is that there's no correlation with time spent, or limited correlation, I would say, with time spent on device. It just doesn't really correlate with the common mental health problems that we're most concerned about when we talk about kids, things like depression and anxiety. If you look at how kids are feeling about their phones and their impulse control around their phones, you see strong signals for an association. So we used a study called ABCD. This is a longitudinal pediatric neuroimaging cohort that is following 10,000 kids across their pre-adolescence and through adolescence. And they've been regularly measuring kids on all kinds of clinical measures of psychopathology, as well as social media addiction or addictive use. But it's these same types of syndromes. I've tried to use my social media apps less, but I can't. I become stressed out or upset if I'm not allowed to use it. And same thing for mobile phones. They also measure video gaming device. And basically, I don't know, the resolution on some of these slides is not great. But this is a paper that we published in JAMA just this last year, showing that when you look at measures of suicidal behavior, it's kids who escalate in their social media addiction that have over 3 times higher risk of suicidal behaviors than kids who use their phones a lot, but don't escalate these types of impulse control and irritability related to their phone use. That's true for both suicidal behavior, so actual suicide attempts, as well as suicidal ideation, and is less true for these other measures of psychopathology. There is some correlation with internalizing and externalizing disorders, but you don't see the same signal as you do for suicidal behavior. And a couple of things that I'll point out. One, to me, this is more evidence of my hypothesis that is really the type of pro-suicide content that algorithms are delivering to kids that is, at least in part, driving those associations. Kids are getting ideas in their head from what they see online, and it's a reinforcing cycle where kids start to become interested, and all of the qualitative data suggests this too. Kids start with curiosity. They start Googling stuff. They start Googling celebrities who've died by suicide. The algorithm sees that, starts delivering them content about it, and it is this vicious cycle of spiral that really is embedded in the algorithmic way that companies make money from keeping kids on their phones. That's just a hypothesis, though. But the fact that you see it for the suicidal behaviors and suicidal ideation and less so for internalizing and externalizing, I think is at least consistent with the hypotheses that I have. And the other thing I'll point out is that there's a lot of methodological room here where we really need innovation, because the other problem is that you have so much potential diagnostic overlap with the kids who report high levels of social media addiction, these impulse control problems. You have diagnostic overlap with ADHD, other kinds of psychopathology and other kinds of psychiatric disorder that also place kids at high risk for suicide. So to what extent are we observing a unique phenomenon that's related to the content and the pattern that they're using on their phones? Or to what extent are we just observing kids who are at high risk for suicide and suicidal behavior as they move through the life course? So I think there's a real opportunity here for methodological innovation. Probably some of the people in this room can do that work. I'm too tired, so I'm not going to do it. I'll leave it to all of you. Okay, and then I'll just end with just an example of how we're trying to take all of this work and use it for inference and forecasting, which as a public health person is really kind of the goal, is we want to be able to tell people in advance, hey, this is what we think we're going to see. This is how public health needs to be prepared for what's coming. And these are the evidence-based strategies to prepare for it. So again, here I work a lot with my colleagues in environmental health sciences who do a lot of this work did a lot of this work during COVID, trying to project what rates of COVID were going to be. My friend Jeff Shaman, who works a lot on this with me, he models influenza, Zika, a whole range of different disorders. And basically, in general, we build these dynamical systems models in order to do it. So unlike regular regression models or correlations, dynamical systems models are process-based. They describe how system properties move and change across time, right? So as an example, if we wanted to create a formula that tells us the movement of a weight on the end of a spring, we could do that in a dynamical system model or a pendulum. We do this a lot for numerical weather models as well, as we're trying to project a dynamical system to tell you whether it's going to rain tomorrow or not. For this work, we use SIR models, which are pretty common in infectious disease and generally stand for susceptible, infected, recovered. So we're applying those same types of concepts, again, to suicide and suicidal behavior, where people who are susceptible are people who are at risk, people who are infected, who are people actively ideating or in suicidal crisis, and people who are recovered are ones who've moved out of that state. We do this we've mostly done this, we're still at step one for this, which is really trying to understand the process of disease. There has been very little attempt, despite all we know about suicide contagion in the US, to actually estimate reproductive rates. So if there's a suicide in a high school or a college or a small town, what is the reproductive rate of suicide contagion for that community? And what are the factors that would influence that reproductive rate to a higher or lower degree? That's where we're at right now in terms of our use of dynamical systems modeling. But the dream, the goal is to, once we understand the underlying process of disease, then we can forecast future outcomes and use counterfactual simulation of alternative outcomes. We've done a lot of the counterfactual simulation piece of dynamical systems modeling for overdose because we're much more advanced in our ability to forecast and predict overdose than we are for suicide. But that's the goal. So we published a paper last year where we focused, I'm trying to bring it back around at the end to where I started, which was celebrity suicide. We tried to model 2 celebrity suicide events, one being the death of Robin Williams, which we've published on extensively, another being several years later, there were 2 celebrity suicides that occurred in the same week. And that was Anthony Bourdain, the celebrity chef and TV host, and Kate Spade, the designer. They died by suicide within about 3 days of each other. And so we consider those 2 different events. And we tried to create a dynamical systems model and write the formulas that would allow us to recover what the patterns of suicidal ideation and death were that would allow us to estimate underlying reproductive rate parameters. So I'm just going to show you an example of that. So as I already mentioned, these were the events that we started with: Robin Williams, the actor and entertainer, and then Kate Spade and Anthony Bourdain as 2 events kind of occurring in quick succession. So basically, this is the type of model that we use, and these are the equations that we used for people to move between states in the dynamical system model of suicide. And the most important parameter we think that we use to estimate is this R parameter, which is your average awareness that someone has died by suicide. So if you can think of a non-celebrity example, right? The average awareness would be acute for people in the community. If someone is in your high school, dies by suicide, for example, there's gonna be a high level of average awareness after that event for the people in the high school, but it's gonna be very local and contained. So you're not gonna have a population impact of that type of suicide death. I think the point of our model is that your average awareness, if we think the average awareness of a suicide death is part of that contagion parameter, a number of people who are experiencing average awareness goes up tremendously when we're talking about a celebrity suicide death, especially someone at the stature of a Robin Williams. That parameter is really going to accelerate. So if you average the entire population of the US, the contagion effect of a non-celebrity is going to be small, but the effect can be large when there's a celebrity suicide. And again, I think it's important to note that it's when the celebrity suicide is inappropriately reported, because there are appropriate reporting policies for celebrity suicide deaths. So not all celebrity suicide deaths increase the population rate. So this was our steady state ideating population that we created in our dynamical systems model. And this is just to show you that a visualization of how we get to these parameters. So we actually estimated on a day-by-day basis how many people are ideating suicide at any one particular time, and we can get that to be stable in our simulated population across time. So we have, the baseline steady state in the population. We have ideation that gets to steady state in the population over model runs. And then we have memory of the removed. So that's your memory after a suicide death. So you can see right here, there's a large increase in memory after a suicide death that occurs at 150 weeks. And then how many people are removed overall. So I won't go through this in a lot of detail. I just want to focus on these 3 panels over here. These are the actual parameters that we estimate in the model. These are the results, our results for the Robin Williams death. So we have baseline contact with people who are ideating suicide. We think that's part of a contagion process. We have your baseline contact with memory. So with your memory of the person who died by suicide, and then ideators who are ideating suicide in contact with the memory of death. And so you can see these are the dates right around Robin Williams' suicide, and we see all 3 of those parameters increasing, which we model projected it would do. So our formulas made that happen. But essentially, using those parameters, we can recover the suicide rate in the United States exactly with our dynamical systems that are underlying those parameters that we estimate over here. We also partnered with the Suicide Lifeline for this work, and we also tried to see if we could recover the number of weekly calls to the Suicide Lifeline right around the time of Robin Williams' death, which increased tremendously right in the wake of Robin Williams' death. And we can recover the empirical number of weekly calls and the empirical number of weekly deaths using these model-based parameters. And essentially, I think the most important thing that this model demonstrates, and again, this is a proof of principle and still just trying to recover those reproductive rate parameters, not trying to do any forecasting yet, is that we can recover the actual number of weekly deaths and weekly calls to the Suicide Lifeline around Robin Williams' death with a tripling of tau. And tau is the contagion contact rate of ideating people with the memory of the person. So really what we're finding in this model, and again, proof of concept type of model, is that it really is people who are in suicidal crisis who are then remembering and thinking about a person who has died that is really allowing us to recover what the actual empirical data shows about the deaths. We see the same thing for the Spade and Bourdain deaths, but importantly, there was an increase in tau, but nowhere near what we saw with the Williams event in our empirical analysis. And that's important because we didn't see the same number of increases in deaths after the Bourdain and Spade event that we did after the Williams death. So the model is not only recovering well the empirical data, but also showing us what we know to be ground truth in terms of the relationship between memory and ideator contact. Okay, so I'll just end, and we have about 10 minutes for questions, and I would love to hear your questions. I think our work generally shows, and I think the first and second slide of this presentation showed that suicide continues to be a national crisis. We're not making the progress that we could. These deaths are preventable, and they devastate communities. I mean, anyone in this room who has a suicide loss in your past knows how impactful these deaths are to families and communities. And I do think a consistent and well-funded public health focus can really make a difference. I also think that a consistent and well-funded public health focus has to pay attention to the fact that there are huge spatial correlations and that there's increasing heterogeneity between high-risk places and low-risk places in the US. And that demands an environmental response, right? We know where high suicide rates are in the US. And so I think that that's really important. And also the temporal correlations are as well, especially these emergent cohort effects for young people, but the cohort effects that we see all across the life course. Core risk factors still need attention, but novel risk factors are emerging that I think are particularly concerning, especially as these new technologies are rolling out in ways that we do not understand and can't control, and we can't put it back in the box once it's out there. I'm working with Australia right now. They just instituted a social media delay for people under 16. And the commissioner of e-safety for Australia always uses this analogy that, like, you know, we know pools are unsafe for kids. We know that kids drown in pools. And so everyone puts a fence around your pool. And like a lot of communities, you're mandated to put a fence around the pool. But AI is the ocean. And there's no fence that you can put around the ocean. So we have to really rethink how we're doing policy, strategy, and intervention for this. And so our group is still focused on novel methods for forecasting and surveillance to try to help these efforts along, and always looking for new collaborations and ideas. And so I hope that some of those emerge today. And so I'll just close with another story. So I told you in the beginning about the sorrows of young Werther and how we use this term, the Werther effect, when we talk about suicide contagion. But there's another story that we talk about a lot when we talk about suicide prevention, which is the Papageno effect. And Papageno was a character in The Magic Flute, the Mozart opera. And Papageno, like Werther, also experienced what he thought was unrequited love. He thought the love of his life didn't love him back. And Papageno also, in The Magic Flute, decides to take his own life. The difference is that in The Magic Flute, the community came out and they tell Papageno that he's a valued member of the community and his life is worth living. And so we talk about that in terms of the messaging that we provide to people around suicide, that we can be recovery oriented. And as a community, we can all make an effort to provide people with safe access to information and a recovery focus that suicide is preventable. So I'll just end with Papageno and thanking my collaborators. Thanks.
Great. Well, we have plenty of time for questions. All right. Start here.
Hi, great talk. Thank you very much. I would assume that AI and social media disturb a little bit those spatial correlations. Has anyone done work into that?
Say that again.
I would assume that AI and social media somehow might disturb a little bit the spatial correlations. Yeah.
I agree. But you know, I think it's been very interesting that at the same time that social media has really grown in terms of not only ubiquity, but also I think the dangerousness with which the algorithms are feeding kids information. It's over that same period of time that you see the spatial correlation increasing and not decreasing, which is not what I anticipated. You know, I thought, well, if all the kids are on social media, then maybe you won't see as much spatial correlation, but you see more. And I don't totally have a hypothesis on why that is, but if other people do, please let me know.
That was not just a fantastic talk, it was quite a disturbing talk. So
Great.
my question is, it's people going through an unprecedented loss of services here in the United States, healthcare, food stamps, other types of services that they rely on. Would you anticipate a significant uptick in suicides in the not too distant future?
I mean, there's an empirical evidence base that those services are related to suicide rates. So the extent to which they're not available, you would anticipate it. Actually, the minimum wage is one of the most effective suicide prevention interventions that we have policies to influence. I will say one thing, which is that people were really surprised during the early part of the COVID epidemic that suicide rates didn't go up, and in fact, they went down in the United States in particular, and in a lot of other countries as well. And there was a lot of concern that suicide rates were really going to increase in that early part of the COVID pandemic because people were shut indoors, gun sales went up, there was a lot of loneliness, there's a lot of grief, you know, all the kinds of risk factors that we think about, but suicide rates didn't go up. In fact, they went down. And there's empirical evidence to suggest that the fact that we had the biggest rollout of government benefits that we've had in this century in the United States for eviction moratoriums, unemployment coverage, that was a suicide prevention intervention. So that, I think, you know, is an example of how we can use those types of benefits, not only for giving people access to food and nutrition, but also to influence mental health. And so the extent to which we're rolling those back, yeah, I think it's going to have an impact on people's mental health.
Hi, that was a great talk. I just wanted to ask you, so you showed an image, a figure looking at states and then firearm ownership, as well as in the suicide rate associated with the firearm ownership, looking at, you know, more firearms leads to more suicides. Do you see in the states that have less firearm ownership, do you see that suicide rate, picking up in other areas? Do you see it kind of like, for example, less firearms, but more asphyxiation?
Yeah, that's a really good question, actually. And in in the American Journal of Epidemiology paper that we showed the map of the United States with all the counties colored in different colors, in our appendix, we actually did the same model for firearm and non-firearm suicides. And you largely recover the same model.
Okay.
So places with high amounts of firearm suicide deaths also have high amounts of non-firearm suicide deaths. It's not a one-to-one correlation, but in general, there's an overlap of that risk. So it's not like in places that don't have guns, people are using other means. And in some ways, and we have empirical evidence in that paper to demonstrate that a lot of those areas are economically depressed, where you have a high number of guns. And so you do have these other kind of structural risk factors underlying a high level of suicide death in particular. But you have a highly lethal weapon that causes suicide in a place where there's a lot of other risk factors for suicide, and those are a bad combination.
Yes, so that was kind of a follow-up question I had there. So in that picture, where you kind of showed all of the different, they were all colors of different counties and looking at suicide rates, and you see, for example, around the coast, right? You see a decrease in suicide rates. So for example, like, how do you measure out confounding variables here when you're looking at some of this, raw data? Do you just contain it all? So socioeconomic status and firearm ownership and all these things. Like, how do you?
That's such a good question. Thank you so much for asking it. So one thing I'll point out is that the deaths on the coast aren't decreasing. They're just not increasing at the same amount. So just as a clarification. And these are high-level descriptive epidemiology. So we're not actually asking causal questions yet. So it's really about documenting the patterns across the United States. Like, it's just a fact that there are more suicides in Montana than there are in New Jersey. But then teasing apart the causal risk factors then becomes the next question. So the extent to which is an economic contribution to it versus another variable that's contributing to suicide deaths in those places. And there the causal inference becomes a lot more tricky because you have all this overlap of risk factors. We're doing a lot of work right now to try to tease apart those types of risk factors. And a lot of it actually is not the confounding challenge, it's the data challenge. We just don't have a lot of information on the types of risk factors that you would need in order to do that kind of more complex analysis. But that's changing. I mean, a lot more data sources are becoming available, and we have more sophisticated tools in order to analyze them efficiently. So I think we're going to be beginning to solve that problem in the next few years. But part of the reason that I've largely focused on descriptive epidemiology is that I didn't have the data and methods to really get at the confounding and the causal questions.
Great talk, thank you. My question gets at the sort of entangling of those environmental factors. So when we have this increase in suicides among a younger cohort, can you look between the US and other countries to see, to try to disentangle, I guess, the macroeconomic factors, where, say, in the US, we might have one sort of outlook on macroeconomic factors for younger generation versus in a country where they have a much different outlook on their economic prospects, where in both those countries, they have very similar things like device addiction, access to internet, things like that. Is there a way to disentangle that, or are they just too different?
No, I mean, I think it's a great project to do, and I think that you should do it. One of the large problems in the cross-country collaboration, especially comparing the US to other countries, is the firearm of it all. We have a much higher suicide rate than a lot of other countries, not all countries, but we have a very high suicide rate for our economic position because we have a lot of guns. So that becomes a challenge then if you're looking at a country level. And there's also a lot of heterogeneity in terms of macroeconomic conditions within the US. So that's why we tend to focus in those comparisons within the US, trying to compare different counties, because once we get outside of the United States, there's a lot of other things going on simultaneously. But I think that it's a good project that we should engage with more seriously. And I haven't seen a lot of work in that area.
I'm going to hop in with one. So I'm a medical oncologist who does a lot of, our focus is on early detection of cancer, looking for biomarkers that predict someone who's either got it or likely to get it. And I'm wondering if there's some related version here where you could look at behavioral activities or things that people do as biomarkers that they're soon to or may act on a suicide, and if there's a way to do intervention that way.
Yeah, there is a lot of work in that space, and I think there's a lot of interest in that space. There's a lot of using actigraphy and kind of daily data to try to anticipate which young people in particular are going to accelerate to suicidal ideation and suicide attempts. And basically my sense of the data, and I'm sure people here know that data better than me, but it's a lot about mood fluctuation. That it's not only, low mood certainly is a predictor, and certainly experiencing depression and other kinds of mental health problems, but it's also a lot of fluctuation. And in particular, from what I've seen of the data, it's young people who both have high levels of externalizing problems and internalizing problems. So angry, aggressive, and sad teens. Those are the kind of group that is at highest risk. And when those emotions are fluctuating fairly regularly, those are the teens that are at highest risk for accelerating to a suicidal state. So what I've seen in terms of intervention development around that kind of preclinical group is trying to identify, in particular, those young people. Suicide death is still very, very difficult to predict, even using daily data, but using clinical data at all. Suicide death is very rare, thankfully, and it's very hard to predict who's going to die and who's not. But suicidal ideation and suicidal behavior is less rare and easier to predict. So that's where I've seen the literature, but I'm sure people in this room know more than me.
Thank you for a really powerful talk. A number of times during the talk, you made a point of emphasizing appropriate reporting of celebrity suicides. And I'm curious about what that looks like and what the evidence base is behind that. Because if it's strong, it suggests a potentially really important moderator, right, of the social contagion effects that you're talking about for preventive purposes.
Yes, thank you for that question. The evidence base is strong. The WHO has guidelines, and a number of other governments have guidelines as well. Essentially, what the guidelines focus on is to not glamorize the death. Don't talk about how someone died, in like specific details of how a celebrity died, and really try to focus on, among other things, on not describing it as a solution to a problem, like not saying this person was suffering and now their suffering is over, right? That doesn't have a recovery orientation. So in Robin Williams' case, I don't know if people remember it, but there was egregious reporting. At one point, the sheriff in the county that Robin Williams died in did a live interview on CNN from the room where Robin Williams died and showed the audience the implements that were used. I mean, it was absolutely egregious reporting. Whereas you have other examples of high-profile celebrity deaths where there was not an increase in suicide. And the most prominent example is Kurt Cobain, who was obviously a well-loved musician and many young people identified with, died by suicide. And there was, I don't think they knew it at the time, but there was a real recovery orientation. Courtney Love gave this really famous speech in Seattle right after Kurt Cobain died. And she said, this is horrible. Like, this was not a solution. I can't believe he did this. He could have recovered. She said all the things that you're supposed to say, and I don't think she was media trained to do it. You saw a huge increase in calls to the Suicide Lifeline, which, by the way, MTV, every single time they reported on Kurt Cobain's death, they showed the Suicide Lifeline on MTV where all the kids were watching it. I mean, I remember being a teenager at that time. They had a huge increase in calls to the Suicide Lifeline and no change in suicide deaths. So just to say, I agree with you.
I just wanted to kind of build off of kind of what Josh was saying and talking about biomarkers and things like that. And it kind of made me think about the samples, right? Like in our instance, like for example, in biochem, right? It's like samples we're working with. You're working with behavior, right? Or in terms of like indicators. So, and you're working with something that's extremely personal to people and something that a lot of the time I would assume they don't want to open up about. My question here is, how do you work with that data? How do you know that the data you're getting is accurate? How do you know that you're getting, accurate amounts of that data of people that might be, having suicidal ideation? Is it from, for example, like, in a form, right? Are you giving people a form, or like, how is that something that's collected? You know?
Very good questions. A lot of different ways. I mean, we do a lot of survey data collection where we just ask people, and hey, in the past year, have you attempted suicide? And there is a lot of error in those questions. And typically it's on the side of people underreporting. When we've done more extensive data collection, it turns out, over our lives, most of us are going to experience a suicidal crisis at some point. Most of us are going to experience suicidal ideation. It's not 20%, it's not 30%, it's probably more like 70 or 80%. We go through hard periods of our lives. So the survey data collection piece, I think, is a challenge. We try to augment it with administrative sources of data collection. So we use a lot of emergency department and inpatient visits, but again, that's relying on physicians coding. And then we do a lot of work with death data. The one thing which again, has a lot of error. There are a lot of counties in the US that won't designate a suicide unless there's a note. And we know there's a lot of suicides where people don't leave a note. So we have a lot of reporting and data quality issues pretty much at every stage. And so, I try to take a Swiss cheese approach. My survey data is not great. My death data is not great. My hospitalization data is not great. But if I put it together, I get some signals, I get some signals of some things. So I think that that's the important thing. The one thing I will say, though, is that families who've experienced suicide loss want to talk about it.
Okay.
And so we do a lot of psychological autopsies, especially after a young person's death, and families find it very therapeutic. So I think that is, but it's hard to do and it's hard work to do. So I think that that's ways that we can kind of get around the sensitivity and people not wanting to report about suicidal ideation. But I think across the board, the issue is a lot of underreporting. So everything I've shown you here is probably a third of what the true scope of the issue is.
And you cannot work with psychologists or things like that due to like HIPAA regulations and things like that? Or is that kind of an option? Is that something that you guys do to look at, maybe some of these government services that you're seeing, right? Where you're reporting some of these government services in terms of like healthcare, things like that, an uptick in that leads to less suicide.
We can look at clinical records.
Okay.
So, and there have been a lot of studies using like commercial health insurance data sets. And so as long as those therapists are coding for suicidal behavior, suicidal ideation, we can see it in the administrative records. But,
Got it. Okay.
you can imagine that probably people underreport that.
Right. Okay. Thank you so much.
Yeah.
All right, well, let's give Harriet